My name's Ted Johnson, and along with Dr. Gabriella Cohen, who's the course director for GM Insights, we wanted to welcome you here today to hear from Debbie Gunter. She is a family nurse practitioner and a hospice and palliative care nurse practitioner. She has over 35 years of experience in a variety of practice areas. She serves as a nurse practitioner in the cognitive neurology clinic and also in the integrated memory care clinic. If I get a call from Debbie, it's a question that will stump me as well. So it's my pleasure to practice with her in that clinic. She supports in the integrated memory care clinic persons living with dementia and their families. She is an award-winning clinician and speaker. And so Debbie, I'm going to turn it over to you. Thanks so much.
Thanks, Ted. Ted knows that keeping to a time schedule is challenging for me. So without further ado, well, I would say in response to if I send you or reach out to you, it's because I'm stumped. But I also try really hard to do some research before I reach out to Ted too, right? So it goes both ways, which is awesome. And I definitely have the privilege in both clinics that I see patients in, the cognitive clinic as well as the integrated memory care clinic, of such fabulous physician colleagues and nurse practitioner colleagues. And I realize how fortunate in both of these clinics we all are to have each other, and both are such collaborative environments, which makes learning fun and caring for patients much more fun. So I have no disclosures to offer about anything. And so we're going to talk as succinctly as I can about the differences between palliative care and hospice care, and how do we explain that to patients and families. And then also think about triggers or situations where you might consider palliative care as opposed to hospice care. So of course, starting with the case, Mr. Johnson, 77-year-old who presents to the clinic with his wife. He has moderate stage Alzheimer's disease with paranoia. He does the typical paranoid things like accusing her of stealing things from him that he misplaces. He tells her there are other people living in the house at times. Mr. Johnson thinks that his memory and thinking is not what it used to be, but he believes that Mrs. Johnson is trying to get him into a nursing home. He's not eating like he used to. He often thinks the food is poisoned. He's frequently awake during the night. He rummages around, he packs, he threatens to leave. He is more incontinent of bowel and bladder, occasionally bowel. Mrs. Johnson has no other family or any type of help, and is feeling very overwhelmed with what is happening and what to do next. So my question for y'all to ponder at this point, you don't have to answer, but ponder, and that is, would you consider a palliative care referral or a hospice referral, or neither? And so I always like to start with what is palliative care. And if we had time, I would ask you for your input in all of those wonderful things to get your ideas about it, but we're going to skip that part of it. And for me, palliative care, to palliate, which basically means to relieve, when you look up the word palliate. So to me, palliative care is a philosophy or the approach that really aims to relieve suffering, improve quality of life for really any patient, but specifically when we target people who have some type of life-limiting, life-threatening, serious or terminal illnesses for the person themselves, as well as for family and who they consider to be family for them. It is a medical board certification specialty, as it is in nursing as well. To palliate, to relieve whatever the symptoms are, whether it's physical or emotional, spiritual symptoms, can happen along with any other medical treatment that somebody is receiving. So if somebody's on dialysis, I can still see those patients. You can still see those patients from a palliative point of view. When we certainly look at our patients living with some type of dementia. All of our dementias that we primarily treat, Alzheimer's, Lewy body disease, vascular, frontal, temporal, dementias are terminal illnesses. Our patients are going to die from their illness unless something else acute happens to shorten that process. And so they may be getting care and treatment for other conditions, and our approach is palliative. And so, like how it should be in all of medical care, one size shouldn't fit all, right? Because everyone is different. So it shouldn't be, oh, we do this for every single patient. No, we're all individuals. So it should be tailored for what this person in their situation needs. And, you know, this approach of thinking about what are someone's goals and how can we help achieve those goals and relieve symptom burden across many, many, many diseases. And so when I think about where does hospice fit in the picture, and you've seen various pictures and diagrams for sure, I know is sort of in the inner circle here of quote modern medicine, meaning dialysis, chemotherapy, radiation, LVADs, inotropes, monoclonal antibody therapy for Alzheimer's disease. Modern medicine fits in the umbrella and circle of palliative care. While you're getting all those things done, are we still trying to keep your goals and manage symptoms in mind? And then hospice at a certain point may be the appropriate next step. And so in our field of palliative care, we say all of hospice care is palliative, but not all of palliative care is hospice care, at least in the United States. And so you've seen some form or fashion of this diagram of, you know, trying to prevent disease in whatever way we all can, but then some type of diagnosis, and in the case we're talking about are different types of dementia, you get a diagnosis and we are treating you and we are trying to help prolong life. And at the same time, hopefully, we are thinking about this person through the palliative lens of what do I know about this person? What are their goals? What's important to them? What distressing symptoms do they have? That paranoia, the depression, the anxiety, to try to manage those. And then as the disease progresses, perhaps goals change. So in our dementia population of patients, and it is now the third aspiration pneumonia and third hospitalization as we've gone along here, and we treated those and the patient was up and ambulatory and talking and, you know, still very functional, to now more decline, we may choose after a conversation to not treat the fourth aspiration pneumonia, to focus on quality and comfort in whatever home setting they might find themselves in. And then we might, at this point, suggest and talk about hospice care for that last 6 months to 12 months of someone's life. And so we're going to talk a little more specifically about hospice too. But I did just want to say about palliative care, there are multiple places, and I think sometimes this is where it can get confusing. So I was part of Emory's palliative care inpatient team for 10 years, helped start the program back in 2006 here at Emory with 3 people, and now there's over 80 people in almost every hospital system, Emory Hospital. So there is tertiary palliative care, inpatient. There is then outpatient palliative care, Emory Supportive Care Clinic. There is home palliative care. And then there is hospice. So there are multiple settings for palliative care. And I guess my point for all of us clinicians caring for people with dementia diagnoses is, for the most part, we all practice primary palliative care. Primary. Understanding, learning what's important to the patient, and that may be through the family, and what are the goals, and having conversations throughout this 8, 10, 12, 15-year process. And obviously trying to have them early when the person might still be able to talk to us about what's important to them. Primary palliative care. Not all of our patients need to be sent, quote, to a specialist palliative care. And so there is lots of research now about the benefits of palliative care, whether it's in the inpatient setting, outpatient setting, home setting, to try and help families and help guide them. Let's talk about, does this make sense? Oh, the recommendation was for you to start on, this happened to me yesterday with one of my cognitive patients, had a remote history of a TIA 15 years ago. The patient got hospitalized up in Michigan for a vasovagal event, and the neurologist up there said the patient needs to be on 80 milligrams of atorvastatin. The patient has moderate Alzheimer's disease with primary aphasia. She is very impaired. Does it make sense to put her on 80 milligrams of atorvastatin when she's already now starting to have problems wanting to take the medications that she's on? So thinking about it through the lens, not just of what's on paper, what are the lab values, but what makes sense for this person? Right? So now think about Mr. Johnson, the patient with the paranoid, delusional thinking, and Mrs. Johnson not having additional help and feeling overwhelmed. Hopefully, and probably everybody's thinking about perhaps some medication changes to see if we could help reduce the delusional thinking. Social service support, educational resources for the wife. And I would absolutely consider a home palliative care referral and talk to Mrs. Johnson about this. And so the challenges with home palliative care is there are not that many options as there are for hospice care. Some hospice agencies have a separate palliative care program, but it is still through the hospice agency. So we often refer to Longleaf Hospice, Bridgeway Hospice, Capstone Hospice have also palliative care, meaning someone doesn't sign up to start their Medicare hospice benefit. Most of the time, home palliative care involves a palliative care nurse practitioner coming to the home at least once a month. It might be a little more than that, depending on what's going on with the patient. So home-based palliative care does not have the whole support circuit that hospice agencies have. But we have found it helpful for the caregiver to know that they have an expert coming, and they can also serve as a bridge between what is happening in the home and us as the clinician, as the providers. And then as things progress, then it often can be a more natural conversion then to home hospice services. Because not everybody qualifies for hospice care, right?
There's a question that's timed for what you just said, and if you can't easily see the chat,
okay, I just did.
Our colleague Annie Syed.
Yep. Well, I think counseling the family as they navigate the last weeks is their end of life management. It's very variable depending on who's directing the hospice agency. Hospice medical directors are not always hospice and palliative care trained or boarded. How do you think standards of care can be made uniform across hospice agencies? What a fabulous and wonderful question that I so wish I had the perfect answer for, because you are exactly right. I think with hospice medical directorships, and training, they are probably very similar to 20 years ago with nursing home medical directors not having that consistent training and specialization. But you are absolutely correct in that. And yep.
For those having trouble reading the chat, basically the comment was, not only is there a problem with availability of palliative care services from home health agencies and home hospice agencies, but there's also a level of expertise that you would like to get, but you don't always get. So thanks for that question. Thanks for that answer.
Absolutely. Absolutely. Yeah, we all certainly see it with home health services, with PT, OT services sometimes, and see the variation in the approach with it. I think palliative care and home palliative care and even hospice now compared to even 10 years ago or 18 years ago, when inpatient palliative care was starting and having been maybe 5 years infancy to board certification and specialization. And so we're still in that infancy outside of inpatient. My hope is that we will continue to see more attention, more education, and advances in that area. So here's my second patient. She's actually a patient of mine with Lewy body dementia, who is in the very late stage of Lewy body dementia. She's bedbound, oriented to person, we think, off and on. She's lost 30 pounds in the last 6 months. She's been to the hospital about 3 times for aspiration pneumonia. Obviously, the admissions were complicated by acute delirium on top of her dementia, and of course, a new stage 3 pressure ulcer. You're wondering about hospice for her, but hesitate to bring it up because her husband has always described her as a, quote, fighter who wouldn't want to give up. Her husband has had to hire in-home caregiving help and worries about how are we going to afford this for another 5 or 10 years. So it's my patient example, but not my example about the hospice conversation. But what are you thinking at this point? Hopefully a couple of thoughts in this example. But I just want to get through really quickly the basics with hospice. Probably the majority of you are certainly aware of them, but who is hospice for? Anyone who is estimated to have a life expectancy of less than 6 months. The important part of this statement is if the disease runs its natural course, because we cannot absolutely say you're going to die in 6 months. But if the disease that I'm looking at runs its natural course, would I be surprised? What is it? Focusing on caring for the whole person, not curing not life prolongation from specific medical interventions. When is it appropriate? When the patient also says, I'm done, I don't want to continue chemo, I don't want to continue on dialysis, I don't want to continue with whatever it is. When the disease-modifying treatments are no longer beneficial, we hope that our medical providers would say, this isn't working anymore. We need to stop and focus on a different outcome here. When disease-modifying, when the burdens of treatments outweigh the benefit, when the goal is not to return to the hospital for a medical crisis, where can it be offered? Anywhere. home, nursing homes, assisted livings, hospital, freestanding hospices, or what we refer to as inpatient hospices. How is it provided? And in the United States, we know it is an insurance benefit. Okay, so the US is different from other countries that may have nationalized healthcare, where hospice and palliative care mean the same thing, that there's not a time frame put on the care. But for us in the United States, hospice, Congress passed the hospice Medicare benefit law in the early 80s to say, oh, people say they want to die at home. Let's help them die comfortably at home. Pretty much most private insurances follow the Medicare guidelines. Medicare typically follows Medicare guidelines, of course, recognizing that Medicaid is also still state to state. There can be variations. The VA has hospice provisions different than Medicare in some ways. And then most hospice agencies also provide hospice services for people who don't have insurance. Many hospices have a philanthropic foundation that helps be able to take patients. Can somebody still be a full code and receive hospice care? Absolutely, they can. Can somebody have a PEG tube and be eligible for hospice care? Absolutely, yes, yes. And so again, focusing on if this disease, despite the PEG tube, despite being a full code, despite whatever it is we're doing, do we still expect this disease to run its course over the next 6 months and likely result in death? I'm not going to get into all the levels, but I did just want to put that there are 4 different levels of hospice care that every hospice agency is required to be able to offer. By and large, the most common form or type or level of hospice care is at someone's home. Again, wherever their address home is. But there's also continuous home care for periods of crisis, symptom crisis, where people would come, nurses, nursing assistants come to the house for a 24-hour or 48-hour period of time. So that is a crisis-driven level. Inpatient respite care. Someone's receiving hospice care at home. The plan is going really well. They're doing well, but now the family says to their RN case manager, you know, we have to go to our granddaughter's graduation in 2 months. What will we do? Because we can't leave, you know, so-and-so at home. And they would help arrange an inpatient admission, say, to a nursing home, assisted living. And then what's considered the highest level, highest reimbursement amount is general inpatient care, or GIP level of care. So this is where someone goes to a hospice facility, a hospice bed somewhere because they need intensive symptom management. They need 24-hour nursing oversight. They need a physician seeing them every day. So inpatient hospice care is a small part of overall hospice services. And people can go from one level to another. Maybe their pain gets out of control and they go to the inpatient unit. They make some really aggressive pain management changes, and then they go home and have their home team see them. I think what's important for us when we're thinking about hospice services is that, do we expect that if the disease runs its natural course, that their life expectancy would be roughly around 6 months? And usually it's the primary care physician or a specialist, like in my setting of neurology. There are general prognostic guidelines. Do people survive past 6 months? Absolutely. Absolutely, they do. if they are remaining on hospice services, they have to continue to show a persistent decline in their conditions. Sometimes patients, many of our geriatric patients end up in the hospital. Debility, right? Because we don't get them up as frequently as they need to get up. Whatever the disease is, they get weak. They start having trouble swallowing. Oh, speech therapy sees them, says, oh, nope, they failed their swallow study. Oh, now what are we going to do? Oh, well, we don't want to put a tube down. And so hospice is consulted. They start on their home hospice services. They get wonderful care. And guess what? They start to rebound and start to stabilize. And so after a point, the hospice team would then discharge them, but they could come back on hospice services at a later point. And so the eligibility based on non-disease specific guidelines is a decline in clinical status from their baseline. And then there are disease specific guidelines. So non-disease specifics, this will so not be a surprise to any of you. Decline in performance status, progression to being dependent for activities of daily living. Maybe like my patient, they've got a new stage 3 pressure ulcer. Increasing ED visits, hospitalizations, or clinical visits related to the hospice diagnosis. Progression of the disease as documented by worsening clinical signs, symptoms, lab results. So what we see with decline is considered non-specific disease guidelines. Specific disease guidelines look at, and I'll show you for Alzheimer's disease and other conditions, but it is they have to show a functional decline, whether it's on the Chronosky scale or the palliative performance scale, dependence on assistance for 2 or more activities of daily living, feeding, ambulation, continence, transfer, bathing, and dressing. So Medicare guidelines for ALS, stroke, coma, and dementia due to Alzheimer's disease and related disorders. There are no specific eligibility criteria listed for Parkinson's, other related disorders, MS, or other less common neurodegenerative conditions, but they follow the non-disease specific changes over time. So just because they haven't mentioned, and I will say Medicare has not updated these disease specific guidelines since the 90s. So it is long overdue. So for Alzheimer's disease, a stage 7C cannot walk without assistance, cannot sit up without personal assistance, can no longer smile, can no longer, excuse me, hold up head independently. And have they had an aspiration pneumonia? Have they had a urinary tract infection, sepsis, ulcers, recurrent fevers, inability to maintain sufficient fluid calorie intake over the past 6 months? Have they lost weight? These are the Alzheimer's specific guidelines. And I think we all know the surprise question. Would I be surprised if this patient dies in the next 6 months? And if the answer is no, then 9 times out of 10, they're eligible for hospice care. There are lots of barriers to hospice referrals, and our non-cancer diagnoses, non-cancer conditions are the hardest of all of them. Heart failure, COPD, all of our neurological diseases, they are harder to prognosticate because we could have this person and they could live another 1 to 2 years, right? But the more of the other conditions they start to have begins to drive the decline, I think, faster. Sometimes we're uncomfortable bringing it up. Sometimes we may feel like they need another service that may not be covered by hospice care. We may not know. So don't assume that you know what a hospital, a particular one, might cover. And then we all have had families who are hesitant to talk about hospice. Often misconceptions about hospice. Oh, they just want to kill you. They just give you morphine and then you die, because I knew so and they got hospice and she was dead, 2 weeks later. And as I said, if the patient is still on hospice at 6 months, the hospice is always meeting. They meet once a week, every other week, to review patients. They are always looking to see what is happening with this patient now. They don't want to provide services and get Medicare money if this person does not remain hospice eligible, because that's called the big F word, right? The fraud part of hospice. So nobody wants that. So now think about Miss Jones, our Lewy body dementia patient, 30-pound weight loss, new pressure or ulcer, caregivers at the house. Does she meet criteria for hospice care? Would I be surprised if she died in the next 6 months? No, I would not be surprised at all. And this is just summary about whether it's palliative care, whether it's hospice care, whether it's neither of these, but hopefully when you are caring for your patients living with dementia, that the goals for the patient, understanding that, to me, is the key of providing excellent care for any of our patients. There are some references, and then this was the end slide for the survey.
Debbie, thanks so much. We really appreciate you. This was a great session. You had a nice audience here for this. I hang out with you a lot, and I didn't know that you could not have a DNR and still refer to hospice. And so in looking that up while you were talking, I saw that some agencies might require it, but if they're Medicare certified, they
should not be.
They should not deny your patient's referral based
Correct.
on the patient not family not saying it's a DNR. So that's very useful piece of information.
Yeah, it is. It is not part of the Medicare guidelines at all for hospice care. Basically, somebody has to want it. The services of hospice, they have to forego life, disease modifying treatments, and meet the less than 6 months if the disease runs its natural course. Those are the only criteria.
That's great. This falls under the category of rules that are not rules. So it's always good to find out things that you think you know, but they're actually not true. So thank you for that.
I worked with a former, Laurent Adler, Ted, years ago in the inpatient hospice unit at Bud Terrace when we had it there. And Laurent was the medical director, and we took a patient from Emory University Hospital who had been taken off the vent. She had a trach, she had a PEG tube in, she had been, brain injury, I forget the mechanism, young person. And I struggled some with how does she meet criteria? And Dr. Adler would say, Debbie, don't look at the stuff we're doing to her, look at what's happened to her,
right,
what she's at risk for. And based on that, would you be surprised if she died in the next 6 months? No, right? But it was hard to not look at all of that. The hope, and most hospice agencies will say about the DNR, is that they hope with their care, with their support, with their education from the people who come to the home, that becomes then a natural decision that's made over time. But obviously, sometimes patients may sign up, or their family members start their hospice benefit, and they really aren't in the hospice mindset.
Right. Thank you for that. I wanted to just give a quick opportunity for anybody who might want to come off mute and ask a question. I know we're over time, but we've got a great topic and a great speaker. So
yeah. I tried really hard.
I know you did a great job. You did a great job. All right, then. Hey, well, thanks so much for joining us, everybody. And remember to fill out your survey. Also, we have a YouTube channel. I've always wanted a YouTube channel. Now we have one for Georgia Memory Net Insights. So if you like today's presentation and you know that you missed one earlier that you want to see, you still have the opportunity to do that. So thanks so much for joining us. Take care.
Thanks so much. Bye.